Equity and Fellowship. It's being held at the Student Union Theater. Dr. Lipson is part of the panel. It's going to be moderated by Dr. Waters, who's a clinical psychologist and multicultural specialist in student health and wellness. It's going to feature Cooley Challenger, who includes a faculty member in EdM and also some UConn students. So I encourage you to come. I think it's going to be fabulous. So let me give you a very brief background, because I'm going to let Dr. Lipson do the talking. She's an assistant professor in the Department of Health, Law, Policy, and Management at BU, so our neighbor. She's in the School of Public Health. She's also associate director of the Healthy Minds Network on research on adolescent and young adult mental health, which I believe started at University of Michigan and is now also at BU, so both places. She completed a dual PhD at Michigan in Health Services Organization and Policy at the School of Public Health and Higher Education at the School of Education. Very ambitious. I'm exhausted thinking about it. Her research is very interesting to me, focuses on understanding and addressing mental health disparities in adolescent and young adult populations, especially college students, and it seems like most of your research recently has been on college students. She's researched, published, and also presented on a variety of issues related to college student mental health, including things like anxiety, depression, eating disorders, suicidality, resilience, and mental health over-utilization, among others. She's a co-PI of the Healthy Minds study, which is what I think you're going to be talking about today. It's the largest and most comprehensive survey of mental health on college campuses, so I'm excited to hear about that. She's also a co-investigator on an NIMH-funded study examining the use of mobile technology to reduce mental health disorders in college populations, which is of interest of folks at UConn and InCHIP. So please join me in welcoming Dr. Lipson.
Thank you. I'm so thrilled to be here. This is such a great crowd. And today is actually World Mental Health Day. I'm not sure if that was communicated and it was certainly intentional in the date that we chose for me to come here, but I'm not sure if that was communicated in the in promoting this talk. So I'm particularly excited today to be talking about this topic. And so just a little bit, we just heard a lot about my background, but a lot of people will say, like, oh, you did a PhD in public health and in higher education. Like, what's the connection between those two things? And it's really, there's not that many intersections between the two. And for me, it's really about college student mental health. And that has been my interest for over 10 years now. That's why I went to do a PhD, is because I really saw a lot of challenges related to mental health on college campuses, as well as many, many opportunities. And I had that experience through working in residential life, which I'll talk about a little bit. But my passions are in trying to advance equity around mental health on college campuses, trying to think about how we identify students who are struggling earlier, and really thinking from a population-level public health perspective, from all the way from prevention and wellness through clinical treatment. So today I'm going to kind of define the problem, say, what are we talking about when we think about mental health on college campuses? Then I'm going to present some national data from the Healthy Minds study, which I'll talk more about. And then I'm going to break the talk up into kind of two different pieces. One, understanding mental health disparities, so what do we know about inequities that exist, and then what's being done to address these problems. And then I'll be sure to leave at least 15 minutes for question and answer, but also feel free to chime in. I like when things are as interactive as possible. So we will launch right in. So I became interested in this topic through working in residential life at Harvard College. I was doing my master's in higher education, completely on this path, thinking I wanted to be a director of residential life someday. And my role was, helping design kind of a sense of community within my entryway, helping students potentially with academic problems, breaking up parties. Those are like the three main things that you're told is going to be your role as a proctor, and you're living with first-year students. And by and large, the biggest part of my job felt like I was an untrained mental health professional. I felt like, come to me with a concern related to their mental health, or some amount of time into our conversation, it would feel like this underlying issue that was there that maybe they were or were not understanding at some level, as well as just how much the mental health of peers affects students as well. So really just it was an extremely eye-opening experience for me and made me feel like this is a field that I have a lot of questions about. And if you're someone who's potentially or is in a research field, I think that's probably the biggest indication that you're on the right track, is if you are just curious and you have a lot of questions and potentially feel like you have the potential to make an impact. And that's how I came into to this topic. And so I came into this topic through a very individualized lived experience, but then I came to realize how important mental health is on college campuses, much more from this population level and policy perspective. So the traditional college age, about 18 to 25, directly coincides with the age of onset for lifetime mental illnesses. So 75% of lifetime mental illnesses will onset by age 24. So many students are experiencing these symptoms for the first time when they're at college, and many of them are living on their own or have an enormously higher sense of autonomy and independence than they've ever had before, and at the same time maybe experiencing symptoms that are unknown to them, and the expectation that they would be able to recognize that and seek help is probably not an expectation that we should automatically have, and I felt like that was the expectation that I was seeing. I was seeing a lot of students kind of fall through the cracks. So even more generally, mental health relative to physical health, one of the biggest differences beyond kind of the symptoms themselves, but from a health services perspective, is that the median delay from first symptom onset to treatment contact is about a decade in the United States. So most people, if they're ever getting treatment, are waiting a really, really long time before they do. And there's a huge missed opportunity and so many negative consequences associated with that. And then campus setting. So I think in talking about this, and we see it in the media so much around kind of negative, all of the kind of problems, but college campuses also present a really unique opportunity for early intervention and prevention. So there's over 22 million adolescents and young adults who are enrolled in U.S. post-secondary higher education. So that's over 50% of every high school graduating class is going on to some form of post-secondary education. So if we're identifying adolescents and young adults as a really important population, and in particular this life transition that happens after college, or happens after high school, then college campuses are actually one of the best opportunities to influence the largest number of students. And then it's this really important time from a developmental perspective. And then sort of lastly, there's a much longer list of I think, why there's a unique opportunity if we think about all the different channels like residential life and dining halls and just all the kind of gatekeepers that exist on a college campus. But the third point here is the other kind of like big, like driving selling point behind this, which is that we know that mental health during adolescence and young adulthood, and specifically mental health of students during college, is very predictive of these key outcomes throughout their lifetime. So their social relationships, their economic productivity, and their educational outcomes as well. All of these trajectories are very, very related to their mental health during these college years. So who are today's college students? So college students today are more diverse than ever on so many dimensions, and I just have a couple of examples here. So for example, Latinx students, there's an increase year by year in the percent of students enrolling in U.S. post-secondary education who are Latinx. There are also increasing number of students who are LGBTQIA+, particularly gender minority, transgender students. There's just so many dimensions, and it's really important to think about intersectionality with this in the sense that students possess many different identities, but it's really an exciting time to be thinking about these questions because there is so much diversity that exists on college campuses. So like I said, there's kind of this like bombardment of a dialogue around a campus mental health crisis. And I put that word in quotation expectations here, because I actually don't think that it's really an appropriate word for a number of reasons. And one is that college students are not actually doing worse or better than their same-age non-college attending peers. There's a limited body of research to support that, but the one major national study that compared college students to non-college students of the same age, prevalence rates were very similar, high, but very similar for both groups. The only really significant differences were higher rates of binge drinking on college campuses, and higher rates of psychosis, really serious mental illness among students who are not in college. But I think it's unfair. It's unfair to think of campuses as being just, really unique and having this crisis that doesn't exist elsewhere in society. I think it's if we're going to call it a crisis, it's not one that's isolated to college campuses. And yet we see this everywhere. This media attention to a campus mental health crisis is everywhere. Our research team hears from reporters all over the country who use this language, and we see it every day. So then the big question is, are these problems getting worse? I would say that's probably the most common question that I get, followed by why are they getting worse? And so there's absolutely evidence that that mental health problems, the prevalence of mental health problems, are increasing on college campuses. That's actually not going to be what I focus on today, but I'm happy to engage in that during the question and answer session if that's of particular interest to folks. But here we can just see a number of different indicators: depression, generalized anxiety, social anxiety, and you can see for almost all of them there's an increase over time over the past roughly decade. Same with suicidality. We're seeing increasing rates of suicidal ideation, suicide attempts on college campuses. So there are certain things we talk about all the time with the campus mental health crisis. We talk about suicide. We talk particularly about contagion, and these are really important topics. We talk about digital technology and the effects of social media. We talk about stigma, and we talk about the fact that there aren't enough resources to meet the needs of students today. And all of these things are true, but there's a lot of really important things that we're not talking about. And I think some of the most important things are, we're not talking about the fact that college campuses are more diverse than ever, and what really are the implications of that when we think about the programs and policies that we have and the resources to support student well-being. We're not talking as much as we need to be about the enormous inequalities that exist. There has been, this national dialogue about access to higher education and retention and graduation rates, and the fact that students of color, students from low-income backgrounds, students from other traditionally marginalized backgrounds are less likely to graduate and to persist in college. These are the same students who their needs are not being met with regard to mental health, and where the biggest gaps exist in terms of the supports that we can be providing. We're not talking as much as we need to be about the drivers of inequality, particularly at a system level. So what are the policies that are creating this? And as well as solutions to advance equity. So I certainly don't have answers to any of those points, but I want to be thinking about them a lot. So that's what we'll be doing today. This is just a really quick representation of the research agenda that I have and I continue to have. I think when I came into this field, I thought, I'll start with doing this research, population level research on college student mental health, and then I'll figure out the answers, and then I'll move on to the next thing. I was kind of the naive young graduate student researcher, and more so than even than many other people who I think do kind of take different paths in their research. I've been really squarely focused on college student mental health, and particularly the bottom part of this research agenda, which is collecting the population level descriptive data to be able to understand kind of have our finger on the pulse of what's going on college campuses with regard to mental health, with the goal of being able to use that information to inform programs and policies, with a really big emphasis on disseminating research to be able to inform practice. So one of my favorite things is opportunities to put data and put findings in the hands of people who can make a difference, and that includes students, administrators, increasingly now, much to my happiness, opportunities to connect with college presidents, who really are now, realizing what a priority this is, or have been, but now I feel it more. I think they're asking for researchers to weigh in on this, which is really exciting. So the largest project that I do, and it sort of encompasses everything that I do, is called the Healthy Mind Study, and it's an online mental health survey. And this is a map of colleges and universities that have participated in the Healthy Mind Study in recent years. Colleges and universities elect to participate. We've had about 300, over 300 college campuses at this point that have participated, over 300,000 students. So it's the largest population-level survey about college student mental health, and it with that large sample size comes opportunities to be able to look at populations for whom there's not typically data to be able to say something. So we just did published a paper where we had over 1,000 gender minority students. We were actually able to look kind of within that's a heterogeneous population, and that's a population that has other identities that are held. And so to be able to look at that is a really unique opportunity that's made possible through this large data set, as well as looking at Arab and Muslim students on college campuses and thinking about the unique kind of socio-political factors that may impact their well-being. So we have a fantastic research team that leads the study and runs all the day-to-day operations. My colleague Amber is actually here today, which makes me so happy, here from Michigan. So I'm at Boston University, and the rest of the team is at University of Michigan. I'm starting to work with some folks at BU to build up the team there. We have this wonderful, really collaborative team that makes this possible as a national study. So it's an annual study. We run it every single semester. It's online. It's random samples of students on every campus. So we ask the registrar's office for a random sample of typically 4,000 students, and then we're inviting them to participate in this online survey by email. It's a cross-sectional data set, so it's just a one-time kind of finger on the pulse. What is the state of mental health on this campus? Typically, it's a counseling center director or a high-level administrator who's saying, we want these data. These data can inform our work. We want to bring the study to our campus, and then we run it for them. It takes about 15 to 20 minutes to complete, and response rates are around 20 to 30%. That's one of the key limitations. It's definitely not unique to Healthy Minds. We're making a lot of efforts to try to improve that, but that's one of the key limitations in any survey research on college campuses these days. So the survey is really comprehensive, and in the interest of time, I won't go into this too much, but all of the campuses participate in 3 different sections, which is demographics, the mental health symptoms, and mental health service utilization, and then it can pick from a menu of other topics that we know are really important to mental health and predict and are affected by mental health, including sexual assault, substance use, sleep behaviors. So schools choose 2 other topics that they're particularly interested in, and then those 5 modules create the survey. What's really important is that for mental health status, we're using these clinically validated screening tools. So they're basically the same tools that a psychiatrist or a psychologist or a therapist would administer in a treatment setting. So there's a 9-item scale called the Patient Health Questionnaire 9 that's used to measure depression. So many of you know of that. That's what we're actually using in the Healthy Mind Study. So these are the measures that we're using in the Healthy Mind Study, and these are the outcomes that I'm going to be talking about mostly today. Symptoms of depression, and so these are not diagnoses, these are symptoms, because this is at a population level. Some students have sought treatment, some have not, but we're really talking about self-reported symptoms. So that's kind of the source of data that we're going to be talking about in the orientation. So now, what do we know about mental health disparities? To give us the baseline of what's going on big picture in full college populations, this is the prevalence rates, where we see that about a third of students are screening positive for one or more of these key mental health measures that we're interested in. So it's about 20% for depression and anxiety. Anxiety has kind of been level with depression, inching past depression more and more, and so we're seeing particularly anxiety continue to increase as the most prevalent concern on college campuses. Eating disorders, non-suicidal self-injury, suicidal ideation, and then all of those together, one or more, is about 35%. We measure suicidal ideation, plans, and attempts. So about 11% of students in in the 2016-2017 data had seriously considered suicide in the past year. 5% had made a plan for suicide. About 1% had attempted suicide in the past year. And there's really big disparities, particularly for LGBTQIA+ students in terms of suicide risk. So then we think a lot about who's seeking help and who's not seeking help. So there's a really big treatment gap on college campuses, meaning the proportion of students with apparent need who are or are not seeking help. Less than 40% of students from the previous slide who have some apparent need. And there's absolutely reasons to be thinking about kind of false positives. These are not diagnostic screening tools, but certainly a large portion of students who, for example, are screening positive on the Patient Health Questionnaire 9 for depression have some potential need that we might be wanting to meet, whether that's through traditional counseling services or some other type of support systems. So less than 40% of students with some apparent need are seeking treatment, and that's even among students who say they've seriously considered attempting suicide in the past year, roughly 50% of them have not received any type of mental health services in the past year.
Could you make a distinction between seeking treatment and receiving treatment?
Yeah. So there's a lot that could be said about kind of like treatment adherence over time and really like receiving a high standard of care. This is just, did you have any contact whatsoever? Did you have even just one counseling appointment? Did you have were you on medication in any way for any amount of time? We have done some work looking at like standards of care and whether students are getting like a full dose of treatment. It's a little bit complicated because college counseling centers are not necessarily set up to be able to provide that comprehensive level of care. But that's a really good question. Another really big problem in all of this is that most students who are seeking help are doing so when they're in a crisis. They're not seeking help when they're, beginning to feel this way. And that gets back to what I was saying earlier. These are oftentimes things that students are experiencing for the first time, or they're experiencing them for one of the first times, but in such a new environment and without the friends or the family or the support systems that they had before, and it feels very different. And so they're waiting, and they're not going in and not seeking help until they're really in a crisis. That's a huge missed opportunity, and it puts a big strain on the campus mental health system. So this is, another piece that gets a lot of media attention is basically like college counseling centers are drowning in the demand, and I say we're never going to be able to meet that demand by just continuing to increase the number of counselors that we have in counseling centers. We've seen an increase, and certainly some of that has been necessary, but there needs to be another solution beyond just adding more and more and more resources to a counseling center. So we have seen, this is looking at Healthy Minds study data year by year over a 10-year period and looking at outcomes of any past year treatment, then separately past year therapy or counseling, past year psychotropic medication use, and lifetime diagnoses. And for every single one of these outcomes year by year, we're seeing increases. So we know that the demand is continuing to increase, and part of that is, I'll show a slide a little bit later on, a reflection of some really good things. Like we're increasing knowledge and we're decreasing stigma. So more students are recognizing their need and are going to seek help. Still, oftentimes when they're in a crisis, but we've done a lot of work to make the demand side increase, and we need some better solutions to approach the supply side of this equation. So what do we mean by disparities? I think this term is it's thrown around a lot, and I think it's important before we get into me kind of talking about that to really be thinking about this. So a definition here is it's a type of health difference that's closely linked with social or economic or other environmental disadvantage. So these are disparities that adversely and specifically affect groups of people who've been systematically oppressed or discriminated against, who face greater obstacles to health based on these characteristics that are historically linked to discrimination or exclusion. And so I'm particularly interested, and our team is particularly interested in thinking about disparities by race, ethnicity, gender identity, and gender expression, sexual orientation, religion, citizenship, socioeconomic status, disability, height, weight, body shape. These are all aspects of identities that are closely related to some of the disparities that we're seeing. I'm going to focus primarily on race, ethnicity, gender identity, sexual orientation, a little bit on citizenship and SES today. But if any of those other identities are of particular interest to you, we have a lot of data on them, and I've looked at those identities as well and be happy to talk about that. So this is showing those same outcomes, the rates of depression, anxiety, eating disorders, and past-year suicidal ideation by race, ethnicity. And so that top row there is showing the prevalence rates for white students. And these are mutually exclusive categories. So you can see the last row there for race identity is students who identify as having multiple racial identities. And that's actually one of the most vulnerable groups on campus for almost every measure that we look at. But you can see that there are higher rates of depression, anxiety, eating disorders for many students of color. For students who are multiracial, there's significantly higher rates of all of these. And then Latinx students, higher rates of depression and anxiety. One of the most important things I think to think about is the fact that we're seeing differences absolutely in the prevalence here. The bigger differences to note are going to come when we think about who's actually getting help. Who of these 28% of African American students are actually receiving some type of support relative to white students, and that gap is much, much bigger. So there are so many risks that we need to be thinking about that students of color face when they come to campus. Feeling academically underprepared. There's a demographic analysis. There's an organization that we partner with at the Healthy Minds Network called the Steve Fund, which is the first national organization focused on mental health of students of color, and it was founded by whose son died of suicide. And they really, were thinking about the fact that this was a student of color on a college campus who just did not feel like that campus had the resources or support or understanding to meet their needs. And so the Steve Fund is really trying to fill that gap and trying to really approach this from a place of understanding students of color and their needs and their perspectives and making them be involved in this process. So this list of risk factors comes from research that the Steve Fund has led. So once they're on campus, there's sort of universal challenges that all students face, and then there's some unique challenges to emotional well-being and adjustment to college. So we think a lot about microaggressions and hate crimes. We need to be thinking about that more in terms of what are the implications of that for student mental health. It's also really important to think about the fact that there are protective and inclusive environments. There are institutions where students of color are thriving, and they're not just HBCUs or historically or Hispanic serving institutions. There are places that are doing this better than others, and we have a lot to learn. But factors like microaggressions and hate crimes have a really big impact on student mental health. In the 10 days following the 2016 election, there was an enormous spike in hate crimes. I think we saw that in the media. We remember that. And a big proportion of those hate crimes were happening on college campuses, particularly related to aggressions against international students, African American students, Jewish students, LGBTQ students, and Muslim students. So we saw, a number of really horrific hate crimes that happened on college campuses, and I think the reaction to these is this sense of shock, we can't believe this is happening. I was at University of Michigan at the time. We had one of these incidences, and it was sort of the sense of shock, and it's almost like we shouldn't be shocked about this, that there are really system level and structural aspects to this that are being seen in this really violent moment, but it doesn't mean that they didn't exist before this moment happened, and we can't forget about the fact that this is the reality that students are facing on campus. So we measure discrimination in the Healthy Minds study. This is just a very crude representation of discrimination, and it's another thing we could talk about more if folks are interested. This is just showing for schools that participate in the Healthy Mind Study, so every column is a different institution, and you can see that rates of discrimination of students saying that they have experienced any discrimination in the past year ranges enormously from below 10% of students saying that they've experienced discrimination all the way upwards to about 40% of students saying that they've experienced discrimination. Not surprisingly, experiences of discrimination vary enormously by race ethnicity. I won't dwell on this. The takeaway is that students of color are experiencing much higher rates of discrimination. So we've done an analysis where we were particularly interested in the experiences of Muslim and Arab students on campus. This is actually specifically focused on Arab students, but we've replicated this thinking about religious identity as for Muslim students. And you can see in terms of depression and anxiety that Arab students experienced in fall 2016, right after the election. So it's, seeing the fact that something that's happening out in the world is immediately affecting students. And having the data, I think so often when I'm talking about this, it's like, it's like, rarely like, that's like shocking to me. That sort of like goes with the hypothesis that I would have had. But having the data to really be able to empirically speak to it still feels really powerful. And for me, it's one of the most exciting things about doing this research. So like I said, some of the biggest disparities exist around outcomes related to service utilization. And so we're interested not only in actual, like, who's stepped through the doors of a counseling center or who's had a diagnosis, but what are these really key determinants of help seeking? And so we know that knowledge is really important. We know that stigma is really important. And you can see that in general, levels of knowledge are pretty high. And this is knowledge of knowing what mental health resources exist on your campus. We measure symptoms. We ask sort of some more objective questions, like what are the symptoms of depression and anxiety? And levels of knowledge are really actually pretty high and are improving over time. And there aren't that many disparities in that regard by race ethnicity. There are much bigger disparities when it comes to rates of stigma, particularly personal stigma, and that's measured by items like I would think less of a person who has a mental illness, or I wouldn't be friends with someone who has a mental illness. And so, for example, I'll highlight Asian students in this context. So 20% of Asian students agree with endorse these statements of personal stigma. And Asian students also have by far the lowest rates of mental health service utilization among students in need. So the last column there is any past year treatment for students who have one of those indicators: depression, anxiety, eating disorders, and less than a quarter of Asian students have received any type of treatment. And so that's an enormous challenge for counseling centers and campus systems to be thinking about. I tend to think first and foremost, I never say I have a solution, but I think my first and foremost approach to trying to think about these things is that we need to be involving students. That's the kind of platform of the Steve Fund as well. And we don't see enough of that work happening. And we even see it when we talk to colleges and universities that have participated in the Healthy Mind Study. They're extremely well-intentioned, want to be using these data to improve things, but they're not thinking about how can we actually be talking to this population that we see in our data as being a population whose needs we are not meeting. So we've done a lot of work looking at the mental health of college students of color, and this is just another way of being able to see that. So we published a paper that then got some attention in media, and the Boston Globe covered it, which is really exciting. They did interviews with students of color in the Boston area and their experience on college campuses, which was really eye-opening. So now let's think a little bit about gender minority students. So these are students whose gender identity or expression differs from their assigned sex at birth. This includes transgender students, genderqueer, gender nonconforming students. And in particular, I think one of the areas where we have so much opportunity to create positive change is in our campus policies that we have. So there is enormous variation across the country in terms of campus policies that may uniquely affect gender minority students. So things like name change policies. Are you able to change your name in the campus record, change your pronouns? There's a concept of being dead named or misgendered. And so students are going their college experience, every class they come into, having to correct a faculty member and saying, that is actually not the name that I go by, that's not the name I've gone by for some amount of time. My gender identity and gender expression in no way aligns with the name that you're saying, and those, just constantly having to do that is in and of itself a form of structural discrimination that students are facing. Other policies are gender-neutral bathrooms, gender-neutral housing, student health insurance being inclusive of transgender healthcare needs like hormone replacement therapy. So it's particularly at a systems and structural level, there's so much more that college campuses can be doing. And this has really been the focus of my about a year and a half into my faculty career, and this has really been the topic that I've been most focused on specifically because we really just don't have data. There is not evidence to actually be able to link and say when a student is misgendered consistently due to a system that doesn't allow them to indicate their current gender identity, what is the impact of that on their mental health? I think it's another example of we could very clearly hypothesize that this is going to have a negative impact, but there's very little empirical data to really show that relationship. And my goal is to be able to provide some of that data that can hopefully inform change. And so this is a similar table that we saw before for race ethnicity, this time for gender and sexual minority students. And you can see that for gender minority students, 60% of them are screening positive for depression on the Patient Health Questionnaire 9, relative to 25% of cisgender students in this year of data. 44% are screening positive for anxiety, over twice as much as cisgender students. Eating disorders are higher. Suicidal ideation is 4 times higher. And sexual minority students as well, same trend, particularly students who identify as bisexual. And one of the things that people thought about with this in a lot of ways is are you going to be accepted into the queer community? Are those queer spaces on campus really welcoming you and inclusive to you? And that sometimes bisexual identity sort of falls through there, and there aren't these inclusive spaces for students. So we can see that bisexual students are particularly at risk, and students who are questioning their sexual orientation are also at risk, as well as students who identify as having an other or queer. Yeah.
Are you looking at any intersectionalities between race and sexual orientation?
Yes. So I don't have any slides in this slide deck to show that now, but we have. And so there's important approaches to answering that question. So you don't want to just say, a student of color and a sexual minority, this is the disadvantage associated with each of these, and this is sort of the additive result of that. It's really important to look at the student who is queer and Latinx. And so I'll use that specifically as an example. Queer Latinx students are have some of the highest prevalence rates. But another thing I'll also say is that we just have this enormous data set and a relatively small team, as you can see. So there's researchers all over the country who are using our data. We make it publicly available to anyone who wants to be able to use it. So we've definitely done some analyses on that, not nearly enough. If that's something that, if any of the topics that I'm talking about today, if you think of, I have a research question that seems like it could come out of that, let us know. Amber and I are very knowledgeable about the data set, and we share it almost every day. We hear from folks who are interested in using the data set, and we share it with people and have a lot of resources to support the use of that. So it's a great question, and also would be a great project to take on. In terms of policies that may uniquely affect particularly gender minority students as well as queer students on campus. And so there is an initiative called the Campus Pride Index, which is a policy database of many policies that are on college campuses. And then they kind of rank these schools in terms of how inclusive, how supportive are these campuses for supporting queer students and gender minority students. And interestingly, it's not just the schools you would imagine. It's not just, you know, these like liberal havens that are really excelling. There are some amazing examples of, for example, University of Kentucky has very inclusive policies, at least on paper, at least in practice. And that means something, certainly, to have, you know, anti-discrimination policies that explicitly say, you know, we do not tolerate discrimination based on gender identity or gender expression. And just the fact that there is so much variation that doesn't actually map onto exactly what we would imagine, to me presents an opportunity for, if we can show this data, if we can give this evidence to folks, maybe that could actually create change, because I think that there's sort of just like an inertia around this, a sort of like, oh, these have always been our policies, like, why would we change them? So this is just a screenshot of the Campus Pride Index, which I think is just a really interesting resource, and the work that I'm doing now is trying to link Healthy Minds data by campus to these policies that are contained in the Campus Pride Index to further explore the relationship between campus level factors and outcomes for gender minority students. Sense of belonging on campus. Gender minority students have much lower sense of belonging. They don't see themselves as a part of the college campus. They feel isolated from campus life at higher levels. Stigma, I showed this a little bit before, rates of perceived stigma are much higher than personal stigma, but personal stigma is the only construct of stigma that we see as actually being very predictive of help-seeking behavior. So we really need to be thinking about that 8% of students, and that 8% is disproportionately students of color and international students. And to the intersectionality question, Asian international students have the lowest rates of help-seeking, the highest rates of stigma. And instead of just continuing to point to that statistic as kind of like an insurmountable problem, we need to be creating different programs and resources to reach those students. Just want to make sure I'm definitely leaving enough time. So just a couple slides in terms of thinking about where do we go from here, how do we address these? And I've talked a little bit about this. So really the question is like, how do we address these drivers of inequality? I haven't talked much about first-generation college students, but there's a growing number of students who are arriving on college campuses. Neither of their parents have gone to college. That the transition has a lot of unique challenges for students who do not have parents with college degrees and college backgrounds. And there's been a lot of this literature within the higher education fields, which is one of the two fields that I have training in, and it's not talked about as nearly as much from a public health and mental health perspective. Debt, and I'm sure anytime I talk about student debt and the potential implications of that for mental health, students are nodding. I mean, there's just so much stress that goes along with the enormous cost that comes with college, the stress of taking out loans, the uncertainty of future job prospects. All of that is a really stress-inducing experience for students that we're also not thinking about enough when it comes to thinking about mental health. And so, you know, it's like, oh, you know, is financial aid, or is that an office on campus that should be talking to counseling services and wellness centers? Like, absolutely. The students who are going into or talking with their financial aid counselor in enormous stress, or preparing to come to campus and are taking out an enormous loan, this is something a campus knows. These are not like unknown factors to a campus. And we need to be saying, that's a student that we need to provide extra support to. That's a clear risk factor, a source of stress, and we want the student to thrive. There's no reason that this student can't thrive here, but we need to recognize an enormous challenge that they're facing in terms of their financial stress. So more and more students are taking out loans over time, and we see that financial stress is closely linked to mental health. So this is really just showing that the rates of students who are saying that currently finances are a stress for them. You know, 75% of students are saying that they experience some type of financial stress. There's a really strong correlation with mental health. So students who say that their current financial stress situation is always stressful for them, 60% of them are screening positive for depression, anxiety, eating disorders, the conditions that I was talking about earlier, relative to less than half of that for the students who are saying this is never stressful. And let's think about that in the context of all these academic outcomes that we care about. So the students who are experiencing financial stress, the students whose parents didn't go to college are the same students that were really worried about their academic retention and performance. And many students are reporting that their mental health is impairing their academic performance in college. Gonna definitely skip ahead because I really want to leave time for questions, but we've developed this economic case where we really show a strong relationship between symptoms of depression and retention on college campuses. That's been one of the most powerful arguments that we can deliver to practitioners on campuses. We've developed this return on investment calculator. It's an online tool based on all of our research, and you can enter the tuition rate at your institution and the prevalence of depression based on Healthy Minds data, and a couple of other parameters, and it shows you what is the return on investment. If you were to invest, say, $500,000 in some new mental health prevention or treatment resources, what would the expected return on investment be in terms of tuition dollars retained due to dropouts averted? And on every type of college campus, that return is enormous. It's typically about twofold. And so most of these really big opportunities for investment and return on investment, colleges and universities are capitalizing on that. And so if colleges are thinking about their bottom line, there's definitely an argument to be made for investing in student mental health. We think a lot about how do we make these arguments visually understandable to people and really get this information out there. Our online interactive tool, I think, is one of the best examples of this. We also have infographics and other things. More and more international students, and unique resources that we need to be able to support them. I talked about the Steve Fund. Definitely, if that's an organization that sounds interesting to you or one that you want to hear more about, let me know. We know all of the people who are leading the Steve Fund work, and they're doing some incredible work, and are always wanting to interact with students as well as other researchers. They've created an equity and mental health framework, which has these 10 recommendations for implementation strategies to improve mental health resources and programs for college students of color. And I'll just highlight the very first recommendation, which is identifying and promoting the mental health and well-being of students of color as a campus-wide priority, really making this something that everyone, all the key stakeholders on a college campus are invested in, from staff, faculty, students, and really elevating the student voice in understanding what those priorities are. So just wrapping up really quickly, in saying this, I just wanted to highlight the fact that we think of ourselves in doing this work with Healthy Minds as really trying to provide a service as researchers. So our orientation is really towards translating research into practice. We have this enormous data set that we love being able to share with people, and we love for people to be able to use the data set to do new research, to answer the many questions that could potentially be answered. We have a lot of data dissemination strategies, all of which are free and open to everyone. We have a webinar series, create research briefs. We put out our data in various formats. We have a data interface where you can log in and say, I'm without any data analysis skills. You could say, I'm really interested in, say, symptoms of eating disorders by race, ethnicity, and you just click a couple buttons and it generates a graph for you automatically. We have an annual research symposium that we hold that's open to everyone. That's at University of Michigan, and we have many amazing partnerships as well. And I work with incredible people, as I've said several times throughout this. And yeah, I'm happy to answer any questions, hear people's comments and reflections on all of this. But I'll stop there. Yeah?
What do you mean by stigma?
Yeah, so stigma is a really complicated construct, particularly to try to measure. The research and the literature on stigma has kind of identified multiple different constructs. So I said the distinction between like personal stigma and perceived stigma or public stigma. There's also self-stigma, so I'll go through those, which kind of go from like self, a little bit out, a little bit further out. So starting with self-stigma, that is someone who actually themselves experiences a mental illness, maybe has a diagnosed mental illness, and feels negatively about that. So like it's kind of an internalized stigma. Like I think someone with a mental illness such as myself is less of a person, less worthy of friendship, less worthy of opportunities. So that's self-stigma. Personal stigma is the stigma you hold yourself independent of your own mental health status. So it's like, I would think less of someone who has received mental health treatment. And then perceived stigma is your ideas about what other people think. So I think most people on my campus would think less of me if I had a mental illness. It's this perception. And there's a very big disconnect between public and between the perceived stigma and self-stigma. So that's an opportunity to do some kind of social norming and corrective efforts that students are saying, I feel fine, I don't think less of you, but I think everybody else thinks less. So that's an opportunity, I think, for some really interesting kind of public health and health communication work. And then at the even higher level is the concept of structural stigma. So that's things like policies and systems that disproportionately affect the opportunities of students. So things like the policies I talked about. Yeah.
In the sample, when you were talking about discrimination and university type, how many out of the 300 were PWIs versus MSIs, HBCUs, PCs?
Yeah, so great question. I would love if we could we've done a couple kind of like offshoot versions of the study. I would love to do one that was like specifically with HBCUs. That would be kind of like a dream opportunity for us. We think about it a lot, we talk about it a lot, and we haven't yet been able to get that, that momentum going. We're working with the Steve Fund to try to do that. So we have had historically Black colleges and universities as well as the Hispanic serving institutions. Out of the 300 universities, like off the top of my head, it's like less than 20 that meet that exact criteria. We have had a number of community colleges, a growing number of community colleges. So do you have a sense of how many community colleges at this point? Like maybe like 30 to 40?
Somewhere around 30. Last year we had close to 10.
Yeah, close to 10 just in like 2018, 2019. So community colleges have, higher percentage of students of color on campus. So there's definitely opportunities to look at variations across institutions based on their characteristics. And so we're almost ready to submit a paper where actually the outcome is sense of belonging. It's not even mental health. We're not even looking at mental health in this paper. We're just looking at sense of belonging and how it varies across institutional characteristics, the key characteristic being the percent of minority students, of racial minority students. And finding that, and again, not a surprising, exactly probably what you would imagine with the hypothesis that students of color who are on campuses with high proportions of students of color feel a stronger sense of belonging.
And then, real quick, are there athletes in that sample?
Yeah, there are. And our team has a big interest in athletes, and we have a whole project called Athletes Connected that's run out of University of Michigan still that's really focused on student-athlete mental health. Yeah.
Are you feeding back university-level data to the university?
Yes. So we create data reports. They get a special login to our data interface, so they're able to just see their data within the data interface and say, I want to run this tabulation across academic majors. I want to know how our engineering students or our business students are doing for depression. Click generate graph. They get a graph of that immediately. They also get it in this electronic data report, as well as we actually mail them a data report as well. They get a customized economic case memo, so saying this is the return on investment for your campus based on all of our parameters and based on your tuition rate, based on your prevalence of mental health. Am I missing any key data reporting initiatives?
Are you following them to see what impact it has on policy, et cetera?
Yeah, the question was, are we following what campuses are doing with the data? We make an effort at the end of every year to follow up with the schools and ask them about their experience participating in the study and how they're using the data, and we try to do that kind of over time. It's not as rigorous of data as our survey data with random samples of students. I would say most powerfully is we just hear anecdotes from schools that say, this is what we saw in our data and we did this totally new thing because of it. And so that's really exciting. Another thing that we know is really important to schools is within the data interface, they're able to say, how do we compare to other schools? So they don't see the names of any of the schools. That would be terrible. They just see themselves as one of the bars. Like when I showed rates of discrimination with bars for every institution, they see themselves as a red bar. They see every other institution as a blue bar, except for 10 schools that are closest to them as in terms of their peer institutions. So they can see where do they fall overall, and then also how do I fall relative to my peer institutions, which are defined based on a number of different categories, the same categories that are being used in a lot of ranking systems. So that we know is in just a resource-strapped reality, a way that schools are able to prioritize and say, you know, we're about average on this thing, but we're not about average on this other thing that we really should be trying to focus on. Yeah.
This is, first of all, thank you very much for your work. It's really important, and I think this is what Deb's getting at. Excuse me. People didn't know we just partnered here at UConn along with our undergraduate student government to be a JED campus.
Yes, and
Just about to launch.
yes, we were just talking about that. Yes.
Right here, if you're
Yes.
a student and you get it, take it.
Yes, please.
Information, but and I know Deb and I are working on some projects related to this kind of data. So hopefully in about a year we'll have a little bit of, you know, like really robust information.
Yes, yes. Thank you for reminding me of that. That was one of the things Amber and I were talking about right before. Is just how excited we are to be bringing the study to UConn, because we've never done it here before, so we're really excited. Yes.
So I just was wondering about, I don't know what to call it, but bystander's not really the right word, but I think a lot of times students, they may not seek out mental health help, but they go to their friends.
Absolutely.
And so I'm just wondering if you're capturing that, or if there's any, and then I think sometimes the friends don't know what to do, or they don't want to call the person's parents or go up the, you know, the chain. Yep. Because they don't want to break the confidence,
yep.
But they also don't want their friend to commit suicide,
right.
Or whatever. I'm just wondering if you've looked at that,
yep.
Or if there are, you know, any suggestions for, you know, how people should handle certain situations.
Yeah, that's a great question. So we have done a lot of work around gatekeeper training programs, which are these brief training programs to be able to provide lay people with the skills and knowledge to identify when someone's in distress and hopefully make a link to services. We did a randomized control trial on 32 college campuses where resident advisors were trained in mental health first aid and followed their outcomes over time. We measure upstander, bystander behavior. So upstanding being I see something and I'm going to do something about it, versus bystander is, you know, I witnessed this, but I'm not necessarily going to try to intervene or do something, and then to try to understand why are people not intervening. And one of the key reasons is like I essentially like I didn't feel comfortable. Like I didn't think I had the skills. I didn't think I was the right person to do it, or I thought this person might get mad at me, or, you know, distance themselves from me in some way. In the randomized control trial that we did not see that gatekeeper training. We saw that gatekeeper training had impacts in terms of resident advisors saying, I feel more confident, this self-efficacy was improved, but their actual behaviors, they're reaching out to their students and saying, you know, I want to talk to you, I'm worried about you, and making those referrals was not happening. And we even restricted that to just look at resident advisors paired with students who appeared to be in high levels of distress, so having positive screens for like moderately severe to severe depression, and still didn't see that was happening. There are some limitations to that study, like the time frame may not have been quite long enough to notice some of those impacts. But what I tend to think about with gatekeeper training programs, because when that study came out, it was one of the first studies to actually measure like the impact at a population level relative to all this huge body of data that said like gatekeeper trainings increase knowledge, increase self-efficacy. So therefore, based on this conceptual model, people are going to intervene more and people are going to seek help more. And we were like, well, once we actually measured those things, that didn't appear to be the case. And so it was like, you know, now we're in a position to kind of like defend this. And one obvious way to go would be to be like, gatekeeper training programs are garbage, like they don't work. And yet that's what's happening on all college campuses. It's like one of the most consistent efforts. And so it's definitely not what we want to say. I think there's such importance in doing that. We know that students are going to their peers for help. I think when it comes to gatekeeper training programs in particular, we're making it way too complicated. I don't have a clinical background in any way. I just know that I've gone through gatekeeper training programs and felt overwhelmed by how much information. And I actually think like to distill it down into its most simple components, and to think of it not as like a targeted intervention for like resident advisors, but rather like the saturation approach where everybody has this basic knowledge is it's not necessarily the better approach, but it's a different model. And I think the model that we're currently doing, or that many campuses are currently doing, is not working as effectively as we'd want it to. So, but there's a huge need for that, and that's absolutely. And I think it happens with faculty as well. I think the faculty are in the same position of like, I don't know what to do with a student who's experiencing distress in my office. Yes.
Are you collaborating and comparing internationally?
A little bit, yeah. So that's been really cool hearing from colleges, from universities abroad. So we've done this study now in Ecuador, in Lebanon, had some conversations with folks in London, like in the UK. Yep, United Arab Emirates. Yeah, a little bit. And one of our colleagues is really interested in collaborating with some Chinese universities. So she's starting to think a lot about that as well. So it's open, absolutely. Oh, and Canadian. We've had a big group of Canadian schools that have participated. But we would love to bring it even more internationally because there's a lot of really cool questions to answer there and kind of that like global comparison. There is a study run out of Harvard, the World Mental Health Survey. It doesn't have the word college in it, but it's entirely college focused, and that's a global survey comparing across universities across the world. Mental health. Yeah.
We have to stop, but one final question. So did you make a distinction between students seeking campus mental health services and non-campus? Because I think some people do not do it on campus.
Yep, so we have all of those data. We know, where did a student seek help? How many times did they seek help? And the most common place that students are seeking help is on campus, but it's not exclusive. It's like about 40% of students who seek help roughly are doing so on campus. The other 60% are broken down into much smaller chunks than that 40%. So 40% is the biggest population, but they're also seeking help off campus in their homes and communities, increasingly through online programs as well. Yes.
Have you seen any discrepancies in data when looking at mental health within like the same demographics? For example, like Arab or Asian in a community college versus like a big university?
That's, I think, another question that would be awesome to look at in the data. We haven't, I think because with Healthy Minds data, oftentimes we're like, you know what, the first step is putting like the basic data out there before we can even like get into these other extremely important questions. So we're working right now on a paper that is just doing that comparison between community colleges and four-year schools, because we haven't even put that out with our data yet. But questions like that will likely come from it. And if that's something that's interesting to you, or if there are people who have interest in using the data, definitely reach out to us. It's a great question.